Welcome to TCCC Plus, Day 1, Module 12, about head injuries and secondary injuries. Here we cover recognising and protecting a head injury and managing eyes, burns and fractures at the ASM level. The final H in March is head injury. Suspect it after any blast or blow. Given how much of this war is fragmentation, blast brain injury is everywhere and repeated exposure stacks up. Head injuries usually do not bleed out in front of you. They declare themselves through altered mental status, often over time, so watch the trend, not just the snapshot. Track consciousness with ACVPU. Alert, confused, responds to voice, responds to pain, unresponsive, and go through the initial assessment in order without skipping parts. A casualty who was alert and is now only responding to voice has deteriorated, and that matters. Remember, there are 4 common reasons a combat casualty's mental state drops: brain injury, low blood pressure, pain, and intoxicants, so do not assume it is the head until you have ruled out a treatable bleed. Also consider a safety point that is not negotiable. Anyone with an altered level of consciousness gets disarmed, quickly. Then support the basics that protect the brain. Keep the head up if you can, keep them warm, breathing well and not bleeding, because a head-injured casualty who is allowed to go hypoxic, hypothermic or hypotensive does far worse. Also, avoid re-traumatizing by new head injuries if possible. Then ask for help. The more altered they are, the sooner they need to move. As with other measurements, it is rarely the single point of observation that matters most, but the trend. A casualty who was alert and slides to confused, then responsive to voice, then responsive to pain, is trying to tell you that their brain is in trouble. Record ACVPU regularly and watch the direction. A falling trend is your warning long before anything dramatic happens. When it comes to eye injuries, you should again do as little as possible. Apply a shield, do not probe. You can cover with a rigid commercial shield, or even an improvised cup, or the plastic cup inside an Olace bandage, but never pad with pressure and never remove an embedded object. Treat any eye injury you cannot fully assess as an open globe until proven otherwise, and avoid pressure on it. Do not put drops or ointment in a seriously injured eye, and control nausea if you can, because vomiting raises the pressure inside the eye. Another tip is to not cover both eyes in a tactical setting unless both are injured, because a blinded casualty cannot help themselves. With both eyes covered, they won't be able to evacuate themselves or be any kind of useful. If the eye just has something in it and looks otherwise fine, you can try to rinse it, but if it looks bad, shield and ship. Overall though, decent eye protection matters more than anything you will do after the fact. A large share of combat eye injuries would have been prevented by wearing it. Again, an injured eye gets a shield, not a pad. Any pressure on the globe can push its contents out. If you have no shield, tape a rigid cup or shield to the bone around the socket so nothing touches the eye itself. If an object is embedded, leave it and build a shield around it. Burns are only covered in brief here, with the fuller treatments on the prolonged care day. Recognise the burn, stop the burning, and remove smouldering clothing and anything constrictive such as rings and watches before swelling sets in. Cover with a dry, sterile dressing and do not burst blisters. After preventing further burn injury and keeping it clean, consider the 2 less known dangers of burn injuries. They pour out heat, so prevent hypothermia, and a large burn pours out fluid, so a big burn needs fluids, which is the opposite of the blood-only approach we take for bleeding. At this level, that means recognise the large burn, keep them warm, and escalate to a medic for fluid resuscitation. Watch the airway in any face or inhalation burn because it can swell shut and that window closes fast. Remember that at least a third of burn casualties also have a non-burn injury, so do not let the burn distract you from the bleed. With suspected or obvious fractures, you can splint them as they are, padded, while immobilizing the joint above and below, and checking the pulse and feeling beyond the break before and after you splint. Pass any break in the skin onto higher care, as an open fracture is a contaminated fracture requiring more specialized care. For a mangled or nearly severed limb, control the bleeding with a tourniquet, dress it, and escalate. Do not attempt to complete an amputation in the field. That is not a field procedure. Furthermore, you should suspect a pelvic injury with high-energy trauma, instability, or severe pelvic pain. You can apply a pelvic binder, or a sheet works just as well, to reduce bleeding into the pelvis, but should know what you are doing first. We go deeper on all of these in the prolonged care day. For care under fire, these injuries are not addressed. In tactical field care, your job is to recognise, protect, splint, escalate as needed, while during evacuation, you should monitor and protect. Common errors include dismissing the head injury who is walking and talking now but deteriorates later, removing an object from the eye or pressing on it, and letting a burns casualty get cold or dry out. Let's recap. Suspect a head injury after a blast or blow. Watch consciousness with ACVPU. Disarm the altered casualty. Keep the head up. Avoid hypoxia and hypotension, and escalate as needed. For eye injuries, place a shield, treat as an open globe and avoid pressure. Don't remove embedded objects. Do not cover both eyes if both aren't injured. Regarding burns, apply a dry, sterile dressing. Prevent hypothermia. Give fluids for a large burn. Watch the airway and look for the hidden injury. Fractures should be splinted, check pulses, escalate any open wound, and never amputate in the field. Thanks for watching our TCCC Plus for non-medics Day 1, Module 12 about head injuries and secondary injuries. Next up is Module 13, Casualty Movement.